lists all sorts of appalling side effects which you never want to read, put you off. But it says contact lenses may be irritable and visual disturbances. And again, a very common one, this is a common oral contraceptive, and this is in the SPC, the Summary of Product Characteristics out of the Electronic Medicines Compendium. And I put this in specifically because the undesirable effects mentioned in the table below have been judged by the investigators as having an established, probable, or possible link to the treatment. So all these side effects that we're being told about are possible, but they're not necessarily there. So I think we have to be somewhat circumspect with how we accept what some things are saying, and we have to use our own judgment to think about what's happening. It's quite interesting. I'm not sure I'm really making a point here. I don't know. I just think it's interesting when you look into this stuff and you start really investigating and think, gosh, you know, I've always thought this. And now I'm looking at the evidence there and I'm not so sure it's all there. So here's a case record for you. A patient, a lady, 1932 born. She did report dry eye and she was blaming the Sullipen. Now, these are the drugs she was on. She was on benflumethiazide, which is diuretic, lansoprazole. Then she's on this and then a tricyclic antidepressant. She didn't smoke, she's no hay fever, and so on. Now, and she's got an allergy there. Then we went through all the stuff and we came up with all these things. Phenol red thread was 20. Lids, she had dermatochalasis, conjunctivochalasis, distraction test was poor, snapback was poor, lid cicatrization, and so on. Basically, the diagnosis there was involutional ectropion. There's no suggestion whatsoever of any dry eye produced by a drug. So, now moving on. What if the patient truly has got a diagnosed T. diffuse dry eye, or we're unable for so many reasons to actually resolve the underlying problem? Now, this is important. This is really where we slot in. We know that there's this negative feedback loop now, where the osmolarity goes up, it damages the epithelium, you lose neurological innervation and so on, and the whole thing becomes a spiral, and we have to intervene at this point. Now, how can we do it? The point is here, palliatives are no longer just adequate. Again, back to my patient at the beginning. Palliatives did her more harm than good. I think we need to be looking at hyaluronidates. These are non-Newtonian fluids. We need to be looking at the mucus with acetylcysteine. And again, liposomal sprays can be quite handy. These are actually managing something. They're not just sticking a bunch of drops in. And yeah, for sure, there's steroids and all sorts of things if you want to go one step further. Tetracyclines, incidentally, can apparently help meibomian gland dysfunction as well, and they've got an anti-inflammatory effect. But basically, we're going to be dealing with the first three. And this is a case of mine. This is an elderly gentleman, poor old bloke, poor lids, rubbish lids, about 85 years old. And the staining at the top was what I first saw. Now, there was nothing we could do. His lids were just poor. There was no surgery to put in place. I wasn't going to make him start scrubbing his lids raw because they were just poor quality. They were just old lids. So we decided to use a hyaluronate on his eyes, and we did what I call the marinade approach. We started off 6 times a day. This is non-preserved, remember, non-preserved solutions, so there's no toxicity effects. And we gradually bring it down over a couple of months to a manageable dose. And you can see the result. That the top cornea is when I first saw him, and down the bottom is after about probably 4 weeks, in this case using Blink Intensive. And the effect's remarkable. His eye was comfortable, he was happy to keep going. Again, with a patient like that, that's where the liposomal spray comes in, because again, you're not going to try scrubbing the lids raw. You need some lipid on there though, so it's really, really good. What I would suggest though, is you need to know your own local formulary. Because for instance, hyaluronic acid-based drops are not, there's one in the BNF, but on my local formulary there's none. So I don't bother wasting the patient's time by saying, look, I'm going to prescribe this via GP. I said, look, it's not on there, you can't get it. So it's handy to know. My Northern formulary is always in my briefcase with me, and I know what I can and cannot prescribe from it. So sometimes if the patient's elderly, I have to give them the choice to say, look, you can have a second best option, or you can do this. But these are very, very good for neurotrophic conditions, Bell's palsy, exposure, cicatrized lids, all that sort of stuff where you can't do a lot else. And it's really important. Right, so finally I think I want to mention these 3 things. Now, the first one in particular, seasonal and perennial allergic conjunctivitis, I don't even think of. I would never choose to put this under a dry eye talk. I mention it because it's actually mentioned in that flow diagram that we saw earlier from Hughes. They actually mention it. And I also think it's a very important one, especially for contact lens practitioners, because we've got some really, really good drugs out there now. And one of my standard questions for every patient now is, do they get hay fever? And if they say yes, I then move on and say, does it affect your eyes? And if they start saying yes, I then start telling them about what things. And I think this is so important with contact lens patients, because let's think about it. You want to keep these people comfortable, you want to keep them going. Anything that makes their eyes less comfortable has to make them less tolerant of contact lenses. And I think if we can intervene quickly and look professional, we can make them wear the lenses longer and more comfortably. And they're not blaming the lenses then either. They're saying, oh gosh, yeah, my lenses are a bit uncomfortable because I've got hay fever, rather than because, oh gosh, it's just contact lenses. Now, the old-fashioned way was with the mast cell stabilizers. The problem with these is, like Opticom, they're great, they're fantastic drops, but they have to be, they're licensed for use 4 times a day. Now, that doesn't lock into anybody's convenience, especially not a contact lens wearer. But there are some new generation drugs now, and the one most of us use is olopatadine. This is in the BNF. It's also in, I could argue, every local formulary. You will be able to access this. Now, the trouble with it is it's a prescription-only drug. Now, as a prescriber, I can prescribe it, but you can't always. But you can always write a letter to the GP and say, look, could we get some of this prescribed? They'll prescribe it quite easily. It's now available all over the place. And the beautiful thing about this is it's twice a day. So it slots in really, really neat with contact lens patients. They put it in the morning before they put the lenses in, and then put it in the evening afterwards. It can be used for 2 ways as well. It can be used for longer term chronic control, but also for spike episodes. You know, so if they know they're going out to the country, or they know they're going to go to someone's house with a cat, then they can sort of dose themselves up beforehand. So it's a very, very good drop. I would highly recommend it. And whether you're an IP or not, it doesn't matter. You can prescribe it via your GP, and again, you look good to the patient. The next one was a patient I had a little while ago that came in again to me as a dry eye patient. And again, we did all the work up, we looked at it, and then got a look down, and as far as I'm concerned, she had SLK. So we sent her off for thyroid function tests. And I actually asked, again, if you look in medicines, it says conjunctival resection could be done to get rid of that loose conjunctiva at the top. Actually, the ophthalmologist wouldn't do it, but at least the patient still knows why it is. And again, the dry eye concept isn't there. She has SLK, and we've made a diagnosis. And the other classic one is all the dystrophies. Quite common, I think. Common if you look for them, if you look for your negative staining. And again, you can say to patients, look, we're going to give you lubricants, yes. We're going to do this sort of stuff. So the treatment is the same. Back to that slide very, very early on about how we're putting lubricants in a lot of people's eyes. But there's some really, really valid reasons why we might be doing this. And certainly with basement membrane dystrophies or disorders, lubricants are a really, really strong thing to be using. But again, the patient doesn't think they've got a dry eye. They know they've got a dystrophy. And they can Google it, they can look it up, and so on. But you've made a diagnosis, you've got a management plan, and you work with that. Finally, here's a case then. This is my patient, but I'm not managing it. This is managed under the hospital eye service. And I put this in really to suggest that we're all human, and we all interpret things differently. Now, this patient, okay, they're on some systemic drugs. They're also on, incidentally, a systemic mucolytic as well, so they have COPD. And again, actually, sorry, back a few steps as well. Acetylcysteine is a very, very good drug to use as well. If you've got a lot of mucus strands and so on, that will break it up very, very well. It's called eye lube, and I think it's a really valid drug to use. Again, it's prescription only, but if you've got someone who's got a really, really irritable eye, and these people often do have truly, truly dry eyes, then to prescribe them some eye lube via their GP would be really, really handy. They do sting a tad when they first put them in, but it breaks up mucus really, really well. But anyway, back to this patient for a minute. The person is on a tetracycline for this, which, okay, you could argue has an anti-inflammatory mechanism as well as protecting the eye. But I don't know if you've noticed, this patient's been punctally occluded. Right? They had punctomy. So this patient is being managed under the dry eye system at the hospital. Now, they have gross ectropia. The lid tone's absolutely appalling. The snapback is appalling. Well, there is no snapback. You know, it's out there. It's staring you in the face. You can even see the punctal plug. Now, if you've got a punctum that's nowhere near in apposition with the globe, what's the point of punctally occluding that eye? You've made a diagnosis, and yet they're treating it like it's a dry eye, when as far as I'm concerned, it's poor lid tone. And they've wasted time by putting a punctum in that can't collect tears anyway. I throw it in as a tidbit. It's an interesting thing. We all manage things differently. It's interesting this is under the cornea specialist rather than the lid specialist. I can't believe a lid specialist would do that. But you know, we treat things differently. We look at things differently, and again, we've diagnosed things. So we're all up to it. We all can do it, and we can all make little errors. We're all human. Don't beat ourselves up about it. Let's just keep going and learn from every little mistake. But I must admit, I look at this when I just chuckle at it because I can't understand why he's been given punctal plugs. So there's a thing called clinical knowledge summaries, which is formerly called Prodigy, and this is the first and only time I've ever seen anything plugged somewhere on the internet that's really, really positive for optometrists. And this is my parting note for you. It mentions what a dry eye syndrome is, and it actually says, your GP may refer you to an optometrist for a checkup. An optometrist will use special equipment to examine your eye and will be able to confirm whether you have dry eye syndrome and any other associated conditions and complications. They will also be able to give you advice about treatment. Although your GP may refer you to an optometrist, they are private practitioners and charge for their services. There are a number of tests the optometrist can carry out in order to assess the quality and quantity of your tears. At last, somewhere out there is saying, look, we are clinicians. We have an important role to play in the community, and we can really do things. And the more we show that we can do it, the more we show we can, with good referrals back to GPs, the more they're going to depend on us to do our part. And I think we've got a real future in this clinical side. So, find your own truth is my argument. Get out there, bite off more than you can chew,